My thanks to the organizers for the opportunity to present to the Congress. Unfortunately, circumstances have obliged me to pre-record this presentation. With regard to advances in influenza therapeutics, the introduction of Biloxi into clinical practice represents a major advance in the field. However, COVID-19 and the social distancing measures that have been undertaken have markedly reduced influenza virus transmission. And this has had the consequent effect of delaying the launch or the completion of important influenza treatment trials. At the same time, important studies of immunomodulatory agents for COVID-19 have led to the potential for their trial in influenza as well. Today, I'm going to comment, though, specifically on influenza antiviral agents. These are my conflicts of interest related to influenza therapeutics and vaccines over the last 3 to 4 years. We have 4 major classes of influenza antiviral agents currently. The adamantanes, the first generation antivirals, are no longer in clinical use because of widespread resistance in circulating strains. We've had neuraminidase inhibitors, primarily oseltamivir, for over 20 years, but there is new work going on with regard to alternative agents. Most of the recent work is focused on polymerase inhibitors, and I'll spend the bulk of my time talking about these agents. Studies of antibodies in the form of convalescent blood products date back to the 1918 pandemic, and there's been renewed interest because of broad-spectrum anti-stem antibodies. Turning to the antibody-based therapeutics, this is a summary of randomized control findings. This slide summarizes randomized trials with regard to antibody-based therapeutics. Ivan Hung and his colleagues in Hong Kong conducted a study of hyperimmune immunoglobulin that appeared to reduce mortality if used early in severe pandemic 2009 illness. And this opens the possibility that such interventions may be useful when there are novel strains appearing. However, follow-on studies sponsored by the National Institutes of Health found that high-titer immune plasma and hyperimmune globulin, when added to standard of care neuraminidase inhibitor therapy, did not improve clinical outcomes in hospitalized patients with seasonal influenza A. The anti-HA stem neutralizing monoclonals, which have broad spectrum, have shown inconsistent effects in uncomplicated influenza. One of these, when studied in addition to neuraminidase inhibitor therapy, was ineffective in improving clinical outcomes in hospitalized patients. There is still ongoing work with regard to their potential prophylactic value. With regard to the neuraminidase inhibitors, a significant advance, in my view, is the approval of intravenous zanamivir by the European Medicines Agency. With regard to neuraminidase inhibitors, the approval of intravenous zanamivir by the European Medicines Agency is a significant advance in the field. They concluded that the agent would be indicated for the treatment of severe influenza A or B virus infection when the influenza virus was known or suspected to be resistant to other anti-influenza agents, or when they would not be expected to be suitable for that individual patient. Intravenous zanamivir has been studied across the age spectrum, and no specific drug-related adverse events have been identified to date. Intravenous dosing provides reliable, rapid drug exposure at high levels. In a head-to-head comparison, it was found to be comparable to oral oseltamivir in clinical and virologic endpoints in hospitalized patients, but has the advantage of a high threshold for resistance emergence and inhibitory effects for many oseltamivir-resistant variants, including the histidine to tyrosine mutation in N1-containing viruses. IV zanamivir was used extensively in patients with suspected oseltamivir resistance during the 2009 pandemic. Also, it's more active for influenza B and is an option then for hospitalized influenza B virus infected patients. Let me turn to the influenza polymerase inhibitors. 3 agents indicated each have a different target of action with regard to the trimeric polymerase complex. This is associated with differences in antiviral spectrum, with Biloxi having activity against all influenza types to date. These agents are all orally administered. They show inhibition of viruses that are resistant to our current classes of drugs and show synergy in preclinical models with neuraminidase inhibitors. However, they do differ in terms of their potency, with Promotivir and Biloxi being much more potent than Favipiravir, but these agents also have higher frequencies of variant emergence during monotherapy compared to Favipiravir. Unfortunately, Promotivir is no longer advancing in clinical development. Last year, Janssen announced that both of its trials, one in high-risk outpatients and one in hospitalized, were being stopped following an interim analysis of the results in the hospitalized trial, which showed evidence for futility. With regard to Favipiravir, this agent has been under study for some years. It has restricted approval in Japan for novel influenza viruses unresponsive to current agents. In phase 3 international trials, it showed significant antiviral effects with about a 1-day shortening in the duration of infectious virus detection compared to placebo, but variable clinical efficacy with less effect compared historically to observations with oseltamivir in uncomplicated influenza. Of course, this agent is under active study currently in COVID-19. It has some limitations in that it is teratogenic in multiple species and also has a complex human pharmacokinetic pattern. It induces and is metabolized by aldehyde oxidase, so that this leads to the requirement for loading doses. Also, it's been observed in critically ill patients with Ebola and influenza that the plasma levels are quite variable and tend to decrease over time, so that the optimal dosing regimens of Favipiravir in severe influenza are unclear. Having said that, there is some evidence that the combination of Favipiravir and oseltamivir is superior to oseltamivir alone in severe influenza. This analysis compared 2 cohorts who were prospectively enrolled in studies of either oseltamivir monotherapy or combined Favipiravir and oseltamivir. Overall, 168 hospitalized adults with respiratory failure and in time to treatment from symptom onset of 10 days or less were analyzed. There was a suggestion of improvement in terms of drop in the ordinal scale in the combination group, but more importantly, the proportion who had undetectable viral RNA at 10 days in the combination group was significantly higher than in the oseltamivir monotherapy group. Overall, there was no significant mortality difference. These findings clearly need to be confirmed in further studies, but do offer one potential for combination therapy going forward. Let me now turn to Biloxivir marboxil. This is a oral prodrug of Biloxivir acid, which is a potent CAP endonuclease inhibitor. And the schematic shows a docking model of the active molecule in the endonuclease enzymatic site. Highlighted is the isoleucine at position 38, because this is a key pathway for substitutions that lead to reduced susceptibility to Biloxivir acid. Biloxivir has a prolonged plasma elimination half-life, which enables single-dose therapy in uncomplicated influenza. It has shown greater antiviral effects, but similar efficacy in influenza A compared to oseltamivir in outpatients, but is more effective than oseltamivir in influenza B virus infections. It is associated with the relatively frequent treatment emergence of influenza A viruses, with substitutions conferring reduced susceptibility Such variants retain both fitness and be transmissible from person to person. It has been shown to be highly effective for post-exposure prophylaxis. Let me provide some of the specific data that support these overview comments. These figures depict the changes in infectious virus titer in the upper respiratory tract seen in the Capstone 1 study of uncomplicated influenza, which was done during a predominant H3N2 season. After a single dose of Biloxivir, infectious virus titers were reduced by 1,000-fold compared to placebo at a day after administration, and about 100-fold compared to a 5-day regimen of oseltamivir at this time point. The time to sustained cessation of infectious virus detection was also reduced. Despite this, there was no important difference in the primary clinical endpoint, the time to alleviation of influenza symptoms, between Biloxivir and oseltamivir, both of which improved recovery by about a day compared to placebo. In the Capstone 2 study done in high-risk outpatients, about 60% of the participants had influenza A infection. Here again, there was a superior antiviral effect of Biloxivir relative to oseltamivir and placebo. But again, no differences between oseltamivir and Biloxivir in terms of recovery, both accelerating improvement compared to placebo alone. For influenza B, oseltamivir really had no significant antiviral effect, and here Biloxivir was superior to it as well as placebo. Biloxivir was associated with significant reductions in the incidence of influenza-related complications compared to placebo, primarily reducing sinusitis and bronchitis events. There were very few pneumonias or hospitalizations in this course of this study. One pediatric study compared Biloxivir to oseltamivir in outpatient children aged between 1 and 11 years. The primary outcome measure here was the occurrence of adverse events, which were numerically similar between Biloxivir and oseltamivir, although there was a trend for fewer GI events in the Biloxivir group. The median time to illness alleviation was similar across the groups, as shown in the figure on the right. Of note, the frequency of detecting isoleucine 38 substituted variants was quite high in children below the age of 5 years, over 30%, but about half of that in those between 5 and 11 years of age. This table summarizes some of the other data available with regard to resistance emergence to Biloxivir in outpatients. In the Capstone 1 study of outpatient adolescents and adults, we saw nearly a 10% frequency during an H3N2 season. And indeed, the frequency overall of variant emergence is highest with H3N2 viruses compared to H1N1, both of which are greater than influenza B. Also, there are age-related differences such that the pediatric population, particularly those below the age of 5 years, have the highest frequency of variant emergence. So these variants can have substantial reductions in susceptibility and be associated with prolonged detection of virus. This raises the concern about the potential for human-to-human transmission of such viruses. In Japan, where Biloxivir is approved for use in children, there have been instances of transmission events documented. This is one example in which a 10-year-old child was shown to have transmitted virus to an 8-month-old infant. This was confirmed by whole genome sequencing. Also during that season in Japan, there were 4 other instances where there were H3N2 isolates with the substitution of isoleucine to threonine in children who had not been given Biloxivir, and presumably they had acquired their infection from contacts with others who had been Biloxivir treated. Clearly, this is a circumstance that requires ongoing surveillance. Biloxivir has also been studied in hospitalized influenza patients. Flagstone was a phase 3 randomized study in hospitalized patients with severe influenza. who were enrolled within 96 hours from symptom onset and randomized to a Biloxi regimen based on weight, added to standard of care neuraminidase inhibitor therapy, in comparison then to neuraminidase inhibitor therapy alone. One key exclusion criteria was more than 48 hours of prior influenza antiviral treatment. However, about 40% had received some treatment before coming into the study, which may have been a significant confounder. The addition of baloxavir to neuraminidase inhibitor therapy resulted in much more rapid reduction of infectious virus titers compared to neuraminidase inhibitor therapy alone. The median difference here being approximately 40 hours. Also, treatment emergent resistant variants are less frequent in the combination group, so that substitutions of the isoleucine 38 were seen in only 2% of the combination group, much lower than observed in the outpatient studies of baloxavir monotherapy. And there was also a numerical reduction in the frequency of detecting the histidine to tyrosine mutation at 275 in the combination group compared to neuraminidase inhibitor therapy alone. However, the primary endpoint, the time to clinical improvement based on vital sign normalization or hospital discharge, was not significantly benefited by the combination compared to neuraminidase inhibitor monotherapy alone, so that the median time to clinical improvement was very comparable in the two groups and over time. The 28-day mortality was numerically less in the combination. You can see just under 2% compared to 5% with monotherapy, which is a potential signal, but unfortunately the study was underpowered really for this important endpoint. Let me turn now to the use of baloxavir as a preventive strategy. This just shows the primary outcome in the study that examined post-exposure prophylaxis and household contacts. Clinical influenza developed in just under 2% of baloxavir contacts compared to nearly 14% of those receiving a placebo, giving a point estimate of efficacy of 86%. I would like to highlight two other prevention-related trials of baloxavir. One is a pragmatic cluster randomized trial in nursing home outbreaks in which baloxavir will be compared to oseltamivir for both treatment and prophylaxis in the nursing homes where there are outbreaks occurring. This will include both the patients and staff members. And the primary outcome measure here is the total number of influenza-like illness cases. There will also be data collected, of course, on influenza-specific illnesses, mortality, and hospitalizations. The second study is an ongoing one, the Centerstone trial, that is testing the question of treatment as prevention. Baloxavir or placebo are administered to ill-indexed cases in household units. And the outcome determined in terms of the household contacts, with the primary measure being the proportion who develop RT-PCR-proven infection by day 5. This figure summarizes the outcomes in a number of prior studies of antiviral treatment on influenza events in household contacts. Most of these were observational and small in size, but there have been several randomized controlled trials, including one done in Bangladesh, which suggested a significant benefit with oseltamivir. It's hoped that the greater antiviral efficacy of baloxavir will have even a larger effect with regard to potential reductions in transmission, but that remains to be seen. If it is confirmed, however, that could have major benefits with regard to the epidemiology of outbreaks. Let me now turn to two other agents of particular interest going forward with regard to influenza treatment. The first is Monopyravir. This is an oral prodrug of a ribonucleoside that, once phosphorylated, is an alternative substrate for viral RNA-dependent RNA polymerase and incorporated into viral RNA, leading to lethal mutagenesis. Its antiviral spectrum is broad, including influenza A and B viruses, coronaviruses, respiratory syncytial, and other RNA viruses. It has a high threshold to resistance emergence. Randomized controlled trials in mild to moderate COVID-19 show good tolerability, antiviral effects, and clinical efficacy. And there was the recent press release reporting that in the phase 3 study in outpatients, it reduced hospitalization or death by about 50%. This agent has been recently given conditional authorization in the United Kingdom, and it is under review by the Food and Drug Administration for emergency use authorization in COVID-19. And it'll be very interesting to see how this agent proceeds with regard to its evaluation in influenza. This shows some of the data regarding Monopyravir efficacy in the influenza ferret model, indicating that it has very significant antiviral efficacy in terms of reducing infectious virus titers in both the upper respiratory tract and in the lower respiratory tract for a pandemic H1N1 virus. Similarly, reductions in the upper respiratory tract viral loads were seen in an H3N2 model. The second novel intervention of interest are so-called antiviral conjugates. These are multivalent constructs of broad-spectrum neuraminidase inhibitors with an engineered Fc antibody domain. The multimeric presentation enhances antiviral binding avidity, and the immune cell recruitment by the Fc domain may increase antiviral activity as well. Their spectrum is limited to influenza A and B viruses, but includes some strains resistant to neuraminidase inhibitors. The extended plasma elimination half-life related to modifications of the Fc domain then can lead to the potential for single-dose prophylaxis given subcutaneously or intramuscularly. This is just one set of studies from preclinical work done with one of these, CD377, which was administered 28 days prior to virus exposure in the murine model, and it shows good protection that's dose-related for 2 different influenza A viruses, as well as 2 different influenza B viruses. So to summarize then, optimal treatment strategies for hospitalized patients, especially those who are critically ill, and immunocompromised hosts remain uncertain. I think major advances could be achieved, though, with large-scale trials to assess both antiviral combinations, for example, neuraminidase inhibitors and polymerase inhibitors, in efforts to increase potency and decrease the risk of resistance emergence, as observed in the Flagstone study, but also immunomodulators based on prior reports in influenza, but also findings in terms of treatment of severe COVID-19 used in combination with antivirals. We also have to recognize that despite expert guidelines, antivirals for seasonal influenza are underutilized or often given too late in most countries. And work needs to be done on studies of rapid access strategies and validation of surge capacity to make sure that these drugs can be delivered in a timely fashion. Treatment emergent resistance has been seen in all widely available classes of antivirals, and this obviously calls for continued global surveillance as well as diversification of stockpiles. Thank you once again for the opportunity to present and share these observations with you.